So welcome everyone. It's a great pleasure to be here, and thanks to eCancer TV for inviting me to present you and to discuss the issue of FGF receptor alteration and potential targeting of the gene and the gene alteration in bladder cancer. I'm Andrea Necchi. I'm a medical oncologist, associate professor at Vita Salute University in Milan in San Raffaele. And it's really a pleasure to me to be here discussing with the Professor Eva Comperat from Vienna, from the University of Vienna, who doesn't need an introduction. She's an experienced and expert and top leader pathologist, mainly in the field of GU cancer. Today, we will be discussing regarding many aspects and potential concerns of FGF receptor targeting and treatment in bladder cancer. Basically based on the data that have been generated with FGF receptor targeting in this disease. So first of all, I would like to share with Eva some comments regarding the way to assess the FGF receptor 3 alteration in bladder cancer. We know that there are several ways of assessing this alteration. We have a way of assessing the alteration with the NGS, with the next generation sequencing, with the commercial platforms or internally developed platforms. So looking at the gene mutations or rearrangement. On the other way, we may test this alteration at the mRNA level or even at the immunohistochemistry level. So Eva, what is your feeling as a pathologist, or what would be the future in terms also of reliability and feasibility of genomic testing, the FGF receptor testing in bladder cancer?
Well, I think the most common thing is, of course, the sequencing and RT-PCR and so on. There have been several papers, especially around 2016, where they showed that immunohistochemistry is something which works pretty well. The only problem of these tumors is that very often, if you have a mutation or whatever of FGFR2/3, very often you find these mutations and alterations in the upper part of the tumor, but if you go down in the tumor, as it's very heterogeneous, very often does not have these alterations. So this is a kind of a problem. And this, if you want to do immunohistochemistry, for example, you really have to do whole mount, the whole section, and not only TMAs. The second thing, probably which is not very good to do, is the FISH. You can do, for example, for the gene fusions, you can do FISH, but as the FGFR3 and the most important fusion, the TACC, is very, very close, it can be extremely tricky to make a report, a correct report, because you don't see the signals very well. So probably, for me, immunohistochemistry is really underemployed, because I think it really works very well. It's an antibody which is easy to employ, but the actual standard is, of course, molecular biology.
Great, great. A question that I have to you is related to the fact that we know already that luminal type tumors are enriched in FGF receptor 3 alteration. So I wonder whether the assessment of the molecular subtyping and the assessment, for example, of a tumor as a luminal tumor may be a good surrogate for FGF receptor testing and potential activity of FGF receptor targeting in this disease. I would like to know your view.
Well, it's a little bit complicated, because you have different types of luminal tumors, and the lumina papillary are those which have these FGFR3 alterations. So it's not every luminal tumor. The second thing is we're just writing, the GAPS, the Genitourinary Pathology Society, is writing a paper at the very moment. We're going to submit it, because the problem with this molecular testing and saying, well, we put GATA3 and FOXA1 and so on, and then if it's expressed, it's a luminal type. That's not so simple. It's not validated very often. It's on retrospective studies. We have enormously data, but we do not have validated prospective data. And our recommendation in this paper will be against doing immunohistochemistry to do this kind of molecular testing. We do not think this is really very useful, unluckily.
Great. So back to the data that have been generated on FGF receptor targeting in bladder cancer. We know that erdafitinib received accelerated approval by FDA in the United States based on the data that have been generated in BLC 2001 study, in which erdafitinib was tested in a single-arm, single-group study on FGF receptor mutated or rearrangement tumors, including FGF receptor 2 alteration, 2 and 3 alterations. So based on the data from the BLC 2001 study, which was an open-label, single-group, phase 2 study with erdafitinib that included the patients with FGF receptor 2 and 3 mutated or rearranged tumors to receive erdafitinib as single agent. The study actually provided a response rate of 40% in heavily pretreated patients and actually established a new standard of care. Interestingly, there have been so many data generated as a translational counterpart of this study or retrospective data, for retrospective analysis, post-hoc analysis from this study, looking at many aspects, part of which have been updated and presented at the last ASCO GU meeting. One of the most intriguing data that have been presented to me, and I would like to discuss them with Eva, related to the fact that we have provided a landscape of surrounding genomic alteration that involve EGFR alteration, CCND1 alteration, that BRAF alteration, that could be overall leading to a different prognosis or potentially to a different sensitivity to erdafitinib. So, which is your point of view regarding the developments of targeted therapy in this disease? Shall we look at the overall landscape of genomic alteration surrounding FGF receptor 3, or is everything matter of FGF receptor alterations?
No, I don't think so. I think the surrounding is very important, and something which we really underestimate very often is, you know, the transition between the lamina propria and the urothelium. This is something which is, in my opinion, completely underexplored, because as a pathologist, I can see it. For example, you have different vascularization and so on. You have different stroma. You have more or less inflammation and so on. So I think there are many things which are unexplored. On the other hand, when I look at all the literature, we have now so much data, we now have so much knowledge, and I have the impression that the further you go, the more you really, you know, lose the actually how to treat the patient, because it's getting so complex with the tumor heterogeneity and all these different pathways. And I'm really a little bit afraid that maybe we should be more pragmatic. I don't know. It's complicated. It's really very complicated.
I fully agree, and we also should realize that there is always the distinction and the discrepancy between liquid biopsy and tumor tissue biopsy. We have reported an interesting data, for example, from the Foundation Medicine database. When we look at the fraction of FGF receptor and then the potential matching of FGF receptor 3 alteration from the tumor assessment and the liquid biopsy, and we realized that, for example, a difference of 180 days between the biopsy, tumor biopsy, and the liquid biopsy was significant in finding out a significant difference in terms of frequency of assessment and the reporting of FGF receptor 3 alteration. So the timing is crucial.
And the timing is crucial, but the second problem with all the liquid biopsies, in my opinion, but I'm not a specialist of liquid biopsies, you know, you have a tumor bulk. Something happens inside the tumor and something is outside the tumor. So the tumor is spreading, but probably he's just spreading what is outside of the tumor, and you don't really get what is inside. So this is one of the problems.
Great. And back again to the way of determining the FGF receptor alteration in regard to the use of a specific compounds. We know, for example, that we have a 40% response rate with erdafitinib. Unfortunately, this information and this data have not been replicated so far with other similar compounds. And for example, regorafenib was used based on selected patient population that was selected according to the mRNA expression. So do you think that the way of selecting patients and the way of assessing FGF receptor, back again to the former question, but with a specific aim of looking at the data, might have somehow biased or influenced the results in terms of drug activity?
I don't think so, because I think people are aware that these were selected patients. On the other hand, I think it's useful to select patients with treatments which are extremely expensive, and you don't really know how they will be supported also by the patient. So I think it is a very good idea to do first the testing and then the treatment.
Great. A further point which is highly important in clinical practice is based on the paradigm that FGF receptor altered tumors are less responsive to immunotherapy, or more immunotherapy resistant in principle. Actually, when looking at the data from the BLC 2001 study and potentially other data from a retrospective series, it's pretty unclear whether actually these tumor types are less responsive potentially to immunotherapy, at least to single agent immunotherapy. Which is your impression, your view based on the data?
I had the impression, but maybe I'm completely wrong, that these are more or less immune disearched tumors. So this is probably the reason why they do not respond very well. And from a really practical point of view, when you look at these tumors, I mean, we do not recognize all of them, but there are some tumors which are really extremely papillary, and we recognize them even without any molecular help. And these tumors are never very infiltrated by lymphocytes. And there was a paper where I was co-author recently, where we talked about these large nested urothelial carcinomas, which are really by definition extremely papillary, and they have really overexpression of these FGFR3 alterations. Well, there's a small group of tumors, but nevertheless, these really extensive papillary tumors have a very particular aspect, and for me, they're really more or less immune desert, so that's why they don't react very well to immunotherapies.
And I think that also we should wait for more data on robust data on combination therapy studies aimed, for example, at combining lorlatinib and atezolizumab. But the preliminary data have been presented at ASCO GU this year with an important response rate of 60% in the phase 1 and the phase 1 part of the study. So the potential of shifting the microenvironment from cold to hot by combining the two drugs, or by preceding, for example, as was demonstrated with the enfortumab, an antibody anti-FGF receptor 3, when an induction therapy with an anti-FGF receptor 3 was able to convert or to shift the microenvironment from a cold to hot, and then leading to a response to combination therapy or something like that.
Yeah, but I think, you know, we have, the problem actually is we have to look at several things. We have to look at the molecular classification. We have to look at the molecular classification. We have to look also on the alterations of FGFR3. We also have to look, for example, on the Nectin-4 things, which are pretty new and pretty non-well explored. We do not have very much data on that. And I think also this is something which is really very promising. And I think you should, as I'm a pathologist, of course, not let completely out of sight the really histological point of view. For example, we know that FGFR3 is never expressed in carcinoma in situ, which is really something which is pretty important, I think.
Yeah. So you raised the anticipated and a very important point that I would like to discuss with you in the last 5 minutes regarding the sequencing. We know, for example, that the data that have been just presented a few days ago demonstrated that, for example, luminal type tumors have high expression of Nectin-4 genes, even at the immunohistochemistry level. So, in principle, immunotherapy, erdafitinib, enfortumab vedotin, for an FGF receptor altered tumor, based on the fact that the first line is still a matter of immunotherapy somehow, because we don't have robust data in first line for the use of erdafitinib. What about the post-immunotherapy space? So if a patient is known to have to harbor an FGFR receptor altered tumor, would you privilege the use of erdafitinib in sequencing principle, or would you still privilege the approach of all comers with enfortumab vedotin based on the data?
That's a very difficult question. And I think there's not a complete agreement, because probably I would go for the second based on the data. But it is pretty tricky, because we do not have any guidelines as in pathologists on what we really shall do the testing. This is something which is completely open. Is it the primary? Is it the lymph node? Is it the distant metastasis? So this is something which is after having been treated, shall we do the primary which has been treated? Nobody knows.
It's also interesting to realize that there have been some preliminary data showing that FGFR receptor 3 altered tumors may be less responsive to enfortumab vedotin also. Very preliminary data presented at this year's ASCO meeting, ASCO GU. So it would be great for us as clinicians, because we would be happy to envision a more clear future of sequencing therapy. But I think and I fear that the future will not be so simple to envision. According to you, the expression and the reporting of Nectin-4 as well as of TROP2, which is a target of sacituzumab govitecan, another ADC, which is FDA approved, should be incorporated into the routine practice for pathologists reporting, for example, of cystectomy or biopsies, or not?
Well, if you go really towards the guidelines, the guidelines is always just true pathology without any immunohistochemistry and so on and so on. On the other hand, I think it can be useful, and I think this should be kind of trial. It can be really an European or international trial where everybody has to do the same. We know Nectin is a little bit complicated because it's really overexpressed in many tumors. It's about expressed in, I think, more than 93% of tumors. So, and you have to be aware that it's extremely heterogeneous expressed also in the bladder tumors. So it's pretty difficult at the moment to give really an answer, because I have the impression we really just start, a new chapter, and we do not really know very well where to go. But from a pure pathological point of view, we will not do Nectin to guide you with anything. It's a little bit like PD-L1, which is still not recommended neither in the guidelines nor in pathology guidelines.
Great. And lastly, we should mention important trials that are running in the FGFR receptor targeting space, which are represented, for example, by the Proof 302, which is a trial in the perioperative setting of patients with localized bladder upper tract urothelial carcinoma harboring FGFR receptor alterations, who may receive an adjuvant period of infigratinib therapy and pan-FGFR receptor inhibitor therapy compared to placebo if they have a high-risk pathology, for example, PT3 or PT4 tumor after neoadjuvant chemotherapy. So Eva, my last question to you in these final minutes is about the upper tract tumors. We know that they are enriched of luminal type tumors, so potentially enriched of FGFR receptor 3 alterations. There are trials with FGFR receptor inhibitors like infigratinib in the adjuvant period post-radical nephrectomy, for example. And in this space, we have the data from POUT, from chemotherapy, so a level 1 evidence of the role of chemotherapy in the same clinical setting. So do you think that specifically in upper tract tumors, we will have the possibility to use FGFR receptor inhibitors rather than immunotherapy, mainly in specific contexts like the perioperative setting?
I'm very hopeful that it will work. Yes, indeed. On the other hand, I think we will have to make a really distinguish between these luminal papillary tumors, which are mostly very exophytic and so on. And I think there are other tumors which will not do so well, which are these, which are really invading deeply and then ulcerated and so on. And probably the surgeons during the operation will see pretty well, as well with the imaging, but also because they're in space. They look at the samples, what is going on. I think intraoperative treatment would be for sure something very interesting in the upcoming years.
Okay, so we have touched very briefly many aspects, of course, very briefly, many aspects of the treatment and diagnosis of this specific alteration of the bladder tumor types. So it has been a great pleasure to discuss in these 20 minutes with Eva, as usual. Very insightful comments as usual, and much of the work is should be done, and we have to wait from mature data from big phase 3 studies like the TOR study with erdafitinib comparing with chemotherapy, or other randomized study to declare the success or not of this specific alteration. But they are, of course, indeed very promising in this space for the patients. So thank you very much for your attention. I would like to thank the readership. I would like to thank the audience and of course eCancer TV for this possibility. And thank again Eva for participating and commenting with me. Thank you.
Thank you.